Hi, my name is Jen Morrow. I'm a PharmD and I also am working on my MBA in healthcare management. And today I really want to demonstrate the importance of generating new revenue streams while teaching leadership and not management. So, what exactly is rural healthcare? What makes it different from just general healthcare? Um, we'll focus today on a small group called Oswego Health. It's a small rural healthcare system in upstate New York that has similarities to most rural healthcare systems. They provide an array of services over a very large geographical population. Most of their income, about 90%, is from program services, and payroll is approximately one half of their expenses. Oswego's Health ministers salaries Oswego Health Administration salaries are a modest 1.6% of the entire budget, which just demonstrates their commitment to their mission of this particular organization. Typical administrative salaries for healthcare are between 1.5 and 3%. One of the largest opportunities for rural healthcare is how to provide quality services to a dispersed population. Providing accessible care to rural residents is costly for a health system, especially for specialist laboratory and imaging services. Upstate Medical is stationed in Syracuse, about 40 miles south of Oswego, and being a teaching institution that's owned by the state of New York, it has a huge source of specialists in pediatric services. Many patients will travel very long distances, 3-4 hours easy, because there's services provided there that are not provided elsewhere. One of the biggest expenses for rural healthcare is recruiting specialists at over $500,000 per a particular specialist. A lot of times it's better for rural healthcare to focus on the base customer needs and then send referrals out. So we think of rural, we think of great farmland, but in actuality, rural healthcare has to do with small towns, and not even very small, just small towns, less than 1 million people, and then that happen to be dispersed away from large population centers. So a lot of the challenges for rural healthcare are very common to all healthcare. But specifically the geographical distance that that patients have to go to get health care, and or that healthcare has to travel to reach those populations, getting that care accessible. A lot of times we find in rural healthcare that patients avoid getting care if they can, or for other reasons. And then the patient complexity. So here we'll see that population isn't necessarily uniform, and because of that, the complex cases can sometimes fall through the cracks in a rural healthcare system. A lot of the primary care doctors are required also to basically do the research and become a specialist in many different things to make up for the fact that their health system doesn't have a variety of specialists. More on the administrative and purchasing power, limited resources of rural healthcare, these tend to be even larger limitations for small healthcare systems than they are in a large population center. Also, staffing shortages, you'll see them happen first in rural healthcare, and retaining providers. It becomes a lot of work for a provider to keep up and do all the research needed to take care of these diverse populations. But with the challenges come opportunities. And this is the best place to look for them. Every health system is concerned about the bottom line. Oswego Health is no exception. Readmissions are the largest cause for lack of reimbursement, so declining reimbursement is very, very important. However, a lot of hospitals will come at a place of fear for these readmissions. Another thing for rural healthcare, of course, is the geography. So just trying to find a way to get all of your different buildings that can be spread by 1 or 2 hours of travel time to be cohesive. So this is where culture is going to become important. And of course, we've just seen how a pandemic can force us to spend money on infrastructure. But with that, we've seen a boom in telemedicine. But a lot of times, our rural healthcare population is one of the hardest ones to adapt to these new technologies. So Oswego Health is organized functionally into an FS form corporation. Each division is functional and reports to a centralized operations board, and that each division has a director who reports to the CEO. We're going to see America begin to gray with our baby boomers as they're aging, and there's more opportunity in managing chronic diseases. Oswego Health is responsible for nearly 50% of the healthcare dollars in that market. That, of course, can fluctuate greatly depending on the rural environment. There are some county seats that will be responsible for 100% of their population. Most importantly is the process of turning strategic initiatives into a reality by creating a culture of ingenuity. Oswego Health has an internal organizational identity of being agile, but is that the actual case? So while Oswego Health is considered a small health organization, it has multiple offices over varying specialities, and they're geographically spread out. The physical distance requires that each location is required to have an executive team focused on their particular activities and help forward the strategic initiatives as determined by their abilities. So like most rural healthcare systems, the first initiative that Oswego has is to provide accessible care to their service area. That includes ensuring that the physical locations are accessible as well as having capable providers where they're needed. Recruiting to rural locations is difficult and always expensive. You're going to see this be one of the larger line items for rural health is actually recruiting providers. Also, employee satisfaction can directly affect the healthcare costs. So focusing on candidate retention makes sure that a rural healthcare system is promoting the quality of life in a rural setting, educational opportunities, the health system provided benefits, and then other incentives such as loan repayment or whatnot to try to retain those candidates. Finding the right providers that are capable and then willing to provide the services needed by the community is one of the best ways to spend this labor cost. It means each candidate you're going to take longer looking at, but when you hire them, you're going to keep them. Oswego Health demonstrates the commitment to their workforce by investing in benefits and salaries for the entire team and also limiting those administration costs. The alternative to recruiting doctors is amazing. We have lots of opportunities now, utilizing advanced practice nurses, physician assistants, and pharmacists to bridge the medical doctor shortage is a great way to leverage all the benefits that the health system can bring to the patient. As the pandemic subsides and vaccine administration wanes, it's the perfect opportunity for Oswego Health and other rural healthcare to recruit with an emphasis on being the true hero for your patients. The second initiative for Oswego Health is to focus on quality care, which is demonstrated by the Patient Safety Excellent Award granted from Healthgrades. It denotes that Oswego Health operates in the highest 5% of the healthcare system in regards to patient safety. And as you'll see, using evidence-based practices will make this even better. The third and final strategic initiative is to create healthcare that is cost-effective for patients, for the insurance companies or payers, and the health system overall. Initiatives are often payer or department specific, and cost-effective strategies can be easily improved by using evidence-based practices as well to assess the most problematic areas and identify those solutions. There are many varieties of value-based purchasing programs, and there's no one-size-fits-all program, as each health system and payer has its own dynamics. So value-based purchasing has shown only a marginal effect to the bottom line of most healthcare systems. Most payers have not adopted the scoring-based approach, and it's not shown to be a reliable metric for positive patient outcomes either. But this has not stopped administrators from being fearful and especially trying to fix some of those metrics. Many initiatives have been put forth and some resources have been allocated. The question is if they truly have an impact on patient care. Scoring can be arbitrary from one company to another, and because of the non-consistency, there's no comparable metrics to show the entire story or even to really generate a good evidence-based practice across multiple facilities. Shared risk models are unlikely to have a large impact either on the bottom line. Most of the savings that are achieved through these programs have been passed on to the insurers instead of the healthcare system. Many programs that benefit patients and keep them from utilizing expensive services such as emergency care are expensive to create. And because the small healthcare systems like Oswego Health are unlikely to recuperate the costs of creating patient-centered services within that year or two where you can show it on a budget, they don't even try them at all. Shared risk models simply do not have enough incentive to drive healthcare forward. Full risk models are better at incentivizing patient outcomes to include things like transporting patients to an urgent care facility so that they don't go to the emergency department. Instead, what happens is a lot of patients will wait, and then when things get bad enough, they call an ambulance to arrive at the emergency department, or even instead of the facility calling a cab to pick them up, they use an ambulance, and of course this is much more expensive. A shared risk model has no downside for the health system in this example, so the patient care falters. A shared risk model perpetuates the faults of a healthcare system that does not address the needs of the population they serve. An ancient Chinese proverb states that a leader looks forward 1 year and plants crops, but a leader that looks forward 10 years builds roads. True leaders looking ahead 100 years, they educate the people. This is also the case with health literacy. The true measure of a population health system is to increase the health literacy of their population, which inevitably leads to utilizing only the needed healthcare systems and reducing the overall use of services. Businesses like Oswego Health are in this for the long haul. They are not going anywhere because if they do, their patients won't have anywhere else to go. So how do we utilize an evidence-based practice? So organizational culture of a healthcare system is a mixture of elements, including organizational change, innovation, the culture, managing the organization culture, and applying the findings to implement evidence-based practices. Resistance to change is arguably the largest factor in the success of implementing strategic initiatives. So while not impossible, we must take into account the specific factors that cause resistance and remove them before pushing forward strategic initiatives. Using benchmarks to measure the degree of success of strategic initiatives is important in case a course correction is needed. Companies that use more than 3 benchmarks are more likely to achieve the desired results. Many of the metrics used may be arbitrary or may be impacted by something not relatable to the initiative, so you need to have more than 3 benchmarks. Business is fluid, and by utilizing multiple measuring tools, the healthcare system is more likely to be able to visualize what impact those changes have had in the organization. Benchmarks measures can be financial, marketing, sales goals, safety, labor, environmental. Really, the list is endless. Creativity of the benchmarks is just as important as the enthusiasm for the change. So I know this looks a little busy, but I just want to go through, these are the 9 steps to applying evidence-based practices. So we want to know what we're solving and what does the customer want. We can solve a problem, but if it makes no difference to our patients, then there's no reason for us to do it. What is the data we need and how do we collect it? What are the best practices used by others? So that's where the research and experience of your leaders is going to come in. How do we apply a solution to this problem, and how do we test the solution? 5 and 6 is where you really need to get your frontline people involved, because if they can come up with the solutions and how to test it, more likely they will be invested in making sure that this is implemented correctly. And that leads to 7. How do we move to a fully implemented solution? It's almost going to flow on its own as soon as your frontline workers start communicating what's working and what's not. 8, of course, those are our metrics, and so we can use them to say, hey, is this actually working or not? Does this metric even matter? Those sort of things. And then 9, what time frame do we use to monitor progress? Is this a 6-month initiative? Is this a 3-year initiative? So one of the nice things about using this instead of just simply, profit and loss for the year is that we can create testing progress that may take longer, or we can continue to monitor it over several years and go back that 3 years and not just constantly comparing to the year prior. So here's a good example of applying evidence-based practice. It's one of the best ways to reduce costs and readmission is transition of care. And transition of care is most likely to be centered around retail pharmacy, because this is the one service that a health system can provide that follows a patient from inpatient to outpatient and back again through rehab services anywhere. So by following them through pharmacy, you will be able to get a full view of this patient and their needs. The cost of the transition to care program is really mostly staffing. The median salary for a care coordinator is about $65,000. Considering recruiting costs and everything else of using pharmacists, pharmacy interns, and pharmacy residents, by this graph you can easily see that it is the most economical option available to establish an effective transition of care program. Even though traditionally these programs have been provided by nurse practitioners, medical interns, and doctors. We can even narrow it down that the most economical model is to have 1 pharmacy, a pharmacy resident, 2 pharmacy interns, and they handle 120 demand hours that have costed only $251,000 per year. These costs of these 4 professionals would be paid for by preventing only 6 hospital readmissions per year. The estimated savings to a hospital system by installing a transition to care program is over $4.3 million annually. This is a very easy way to gain money to your bottom line, because without money, there is no mission. This leads us to our recommendations. And the first thing that you're going to notice is that leadership is what drives an organization to be agile so it can best utilize evidence-based programs. The first should be to develop female leadership. Women are considered to develop more collaborations through transformational leadership style. Gender diverse executive teams also experience a greater organizational performance. These are all qualities needed in healthcare, specifically rural healthcare, to embrace an evidence-based approach to the innovations required for the future. Women in healthcare often feel thwarted in their attempts to reach higher executive level positions, and that feeling is backed up with the fact that the percentage of female hospital CEOs has not changed significantly in 3 decades. Over 80% of the healthcare workforce is female, but less than 20% hold leadership roles. This is where we need to stop teaching management, because we're actually finding people don't need managers. What they need are leaders, and we need to teach leadership. And of course, that leads right over to a lot of places need or have initiatives around culture change, helping your workforce become adaptable. To change culture, it's easiest to change the leader, which feeds right into helping women become the leaders that they really should be. Leaders then change the verbiage of an organization, because what you say often will change how people think, and if people change how they think, they will change what they do. Leaders fostering a culture of ingenuity need to translate an organization's values into goals. Often, tension can be created by the pull between problems, potential solutions, and constraints, which is where a transformational leadership style of most females is advantageous to a health system. How we speak to one another often dictates the outcome of these possibly challenging conflicts. Creating leaders that embrace rather than resist or reject new ideas is beneficial to any organization, absolutely essential for healthcare. Language creates culture, therefore, how leaders communicate within tough situations will create or destroy the environment of creativity and ingenuity. The last recommendation is using those evidence-based practices. True transition of care is centered around retail pharmacy. This is the one service that has the greatest impact upon the patient's total health, follows them from home to inpatient rehab and then back home. Pharmacists are uniquely poised to provide inclusive care that can directly reduce healthcare spending and readmissions while also providing positive outcomes. We've seen this inpatient in the last decade as we've incorporated a pharmacist onto every rounding team in every hospital that I've seen. This absolutely works inpatient. It absolutely can work outpatient. So we have the evidence that it works. Now we just need to implement it. A transition to care program is one of the best ways to reduce readmissions. It protects reimbursement for the healthcare system. The cost savings becomes more pronounced when utilizing pharmacy because they're just less expensive than most other professionals, actually in abundance at the moment. Pharmacists are really good at increasing the effectiveness of these programs without increasing the costs. Pharmacy services and copay assistance combined with a transition to care can generate revenue while decreasing readmissions. Having pharmacy services as part of the value generating service can also increase the contract negotiating power of a health system as well. So in conclusion, real quick before the questions, while strategic initiatives require an organization culture that's ready to support change, it's really important for small healthcare systems to be agile and nimble when this change is necessary. Evidence-based practices will put the culture of any healthcare system to the test. Evidence-based programs are an application of the scientific method, and this is just using scientific method for business. It makes perfect sense that healthcare is poised to exploit this system to implement needed changes that demonstrate positive outcomes. Embracing the challenge to solving organizational issues by research instead of personal experience can be an ego deflator for many of our existing leaders. So that's why teaching leadership instead of teaching management increases associate retention. Recruiting costs are extraordinary and only increasing. Retention is the best way to drive down costs while developing the current talent to perform at their personal best. This is the ultimate driver of a health organization's mission to provide the best care possible. Leadership's main purpose is to allow our associates to be the best they can be, and the associates give the best care possible. True leadership must be fostered, and that's when an organizational culture of mutual understanding and language creates bonds across geographical and departmental boundaries. Female leaders are uniquely poised to develop a collaborative environment. Strategic initiatives are most often successful when the exchange of ideas are completely unfettered. Any questions at this point? And then we have a few references for all of that wonderful information. Thank you so much for your time today.